Hi, I'm Keith Williams, and I'm the director of the feeding program at the Penn State Hershey Medical Center. My topic is preventing and treating nutritional deficiencies in children with autism. Perhaps in a news feed, you saw an article that described an adolescent, a 15-year-old male, who developed a visual impairment as a result of eating Pringles and French fries. This story got pretty widespread coverage and was based on an article that was in a medical journal last fall. It's something that we see all the time in our clinic. It's not uncommon for us to see children with a range of nutritional deficiencies. And I want to talk about some of those today because I think that some of you will see these children and are in a position to help by identifying some of these issues early and bringing them to the attention of healthcare providers. As a result of that story about the child that went blind because of his diet, I was contacted by the Guardian newspaper, and they asked me about whether this was typical or whether this was common. And I said it's neither common nor typical for the general population, but certainly there are children and adults that develop health problems as a result of their diet. And some of these health problems can be rather significant, as we're going to talk about today. And I'll give you some examples and hopefully explain why they occur and how you can prevent some of these things. A study came out last fall, which talked about only a quarter of Americans have never eaten vegetables. I don't think that's true because I expect many people ate vegetables as infants in the form of baby food, but then stopped eating them as they transitioned onto other foods. And certainly it's the case that even if a quarter of Americans have never eaten vegetables, there's probably a larger percentage who don't eat enough vegetables or fruits or perhaps other healthy foods as they should. They had a list of the top 10 best and worst vegetables. These are preferences that people have, certainly not based on health value, as you might have noted, because the first 3 vegetables rated as best are corn, potatoes, and carrots. And while all those vegetables are fine, certainly there's other things that might be a little healthier. And regardless, we know that most of the kids in our Commonwealth don't eat the numbers of fruits and vegetables that they should. About 45% of children in southeastern PA, so that's Philadelphia and the greater suburbs, eat 3 or fewer servings of fruit and vegetable daily. And their fruit also included juice. So it really is of fruits and vegetables that are not in the form of a liquid, it's pretty low. During our talk, I want to tell you about some specific nutrient deficiencies that are found in children, especially children that are on the autism spectrum. I want to tell you about why children are at risk for specific deficiencies. We'll talk about some techniques for preventing deficiencies. And finally, I want to talk to you about school-based interventions to help increase consumption of healthy foods and decrease the probability of nutrient deficiencies. You have, if you've gone to the autism conference several times, I'm sure you've seen other people that have presented on feeding issues. Certainly there have been speakers that have talked about food selectivity, including myself, or other feeding problems that are commonly seen in children with autism. This time I wanted I selected this topic because I've seen children with scurvy. In fact, in the last year, I've seen 7 children with scurvy. I've seen children with vitamin A deficiency. I've seen a child with pellagra. I've seen iron deficient anemia, pretty often, and I've seen vitamin D deficiency. Many of these children with deficiencies should have been diagnosed or treated much earlier. We've diagnosed a number of these issues in our clinic, and I think probably they should have been diagnosed before they ever came to the feeding program. Therapists and nutritionists working with children with special needs, especially if you're working with them in the home or community, are often in a much better position of understanding the child's nutritional environment than healthcare providers. The primary care provider sees the children, and usually after they've are no longer infants, they don't see them that often, maybe once a year. And in the well child checkups, the visit's not very long, several minutes at most. So they really don't have time to look at what is the child eating and is their diet sufficient? Certainly it's not that they don't care or they don't want to, but that's just often not a focus of the visit because there's all kind of other issues that they have to get to. And during sick visits, the focus is typically on an illness or an injury and not on the child's eating patterns, unless the illness is secondary or to the eating pattern, but that's less typical. There are a number of children, and we see some of them in our clinic, that have nutrient deficiencies that are based on medical conditions that they may have. And I gave a couple of examples here, like vitamin A deficiency is common in cystic fibrosis. Children with GI disease, especially GI disease where they've got problems with the lining of their gut, often lose blood through the gut, and as a result of that, they may have iron deficiencies. Kids with malabsorption problems like Crohn's disease or celiac disease are at risk for vitamin C deficiency. You're gonna, no doubt will see children that have nutritional deficiencies secondary to various medical conditions, but it's also important to see if poor diet is playing a contributing role. In the talk today, I'm not really gonna talk about that. My focus is gonna be on nutritional or nutrient deficiencies that are secondary to limited diet. So kids whose poor diets lead to these specific nutrient deficiencies. That's what I'm going to talk about in this talk. As a society, we focus huge amounts of time and resources on what are relatively lesser threats to public health. It is absolutely appalling hearing about an infant who's been locked in a hot car and may have not survived or may have brain damage. But even though we hear about those on the news, those events are relatively rare. The opioid crisis, thousands of people have died, 80,000 a year perhaps. But overall, even that is not that large a number. Smoking impacts millions of people over time, but still, when you consider in 2017, 11 million deaths were attributable to dietary risk factors. So there are people out there, millions of them, who die every year because they've got problems with wellness. They're not eating the right foods, they don't engage in physical activity, and as a result, they develop chronic health conditions, which eventually lead to their demise. Providing children and adults with balanced diets would largely resolve the occurrence of most nutrient deficiencies, and it would also help decrease the prevalence of many chronic diseases. As providers, helping children learn to eat new foods is an important goal. If you look at the current setting, the three most common COVID comorbidities are hypertension, obesity, and diabetes. All of these things are influenced by diet. So why do we eat healthy? It's going to help us protect us from this pandemic and the next one. So if we don't have some of these comorbidities, it makes us less likely that we're going to get seriously ill from COVID or other viral infections. Now, why is iron necessary? Well, iron is the carrier of oxygen to the tissues, and it transports electrons within the cell. Iron is why your blood is red. There is documented evidence that iron deficiency adversely influences cognitive development and intelligence. Iron levels are also related to behavioral symptoms in children with ADHD, and iron deficiency may compromise communication and behavior in children with autism spectrum disorders. There's a pretty robust body of research that talks about the effect of iron on development and shows how critical iron is to human development. Iron deficiency is widely prevalent. Iron deficiency is just low iron. Anemia is a lack of hemoglobin. So iron deficiency anemia is both low iron and low hemoglobin. Iron deficiency affects about 2.4 million children, and iron deficiency anemia affects about 490,000 children. Iron deficiency is found in about 15% of children aged 1 to 3 years. So if you look at a group of 100 preschoolers, or toddlers, I guess it would be, about 15 of those toddlers have iron deficiency. In a group of about 100 of those toddlers, 8 of those children have iron deficiency anemia. Those are huge numbers of the pediatric population. Children with special needs are especially high risk. Iron deficiency is the most prevalent iron nutrient deficiency, and certainly by far the one that we see most often in our clinic. In this chart, the top line shows the results of a CDC sample. They looked at a large pediatric population, and they found that in that population, about 9% of children had iron deficiency, and about 2% had iron deficiency anemia. The other lines in that chart are samples of children that are on the spectrum. The sample sizes are all small, ranging from 31 to 222 children. But generally, with the exception of one study, the Reynolds 2012 study, all the samples had a higher prevalence of iron deficiency, and the ones that measured iron deficiency anemia had a higher prevalence of iron deficiency anemia than the population sample collected by the CDC. The only exception, as I said, was the Reynolds sample, which about 8% had iron deficiency, which is very close to the general population. And only one child of 222, which is even lower than the general population, had iron deficiency anemia. So as a general rule, kids with autism have a higher risk of being iron deficient. Common symptoms of iron deficiency anemia include feeling tired, paleness, difficulty breathing, fast heartbeat, dizziness, headache, feeling cold, especially the sensation that your hands or feet are colder than usual, infections, pica, or eating items that are non-food, pagiophagia, which is eating ice, and beatyuria, which is red colored urine. The most significant cause of iron deficiency that's the result of diet is because of the overconsumption of milk. It's pretty typical for us to see children who are toddlers or preschoolers who drink 40 to 100 ounces of milk a day. In some cases, milk is by far their largest source of calories. And the problem with this is that calcium and casein that's found in the milk block the absorption of iron. So many children that drink huge amounts of milk develop iron deficient anemia. And for some of the kids that come into our clinic, I tell the families, I was like, with the child's with the diet you're describing, that is a recipe for iron deficient anemia. So if they don't have it yet, they will have it if they continue on this path. Not only does iron deficiency anemia affect brain development, it also suppresses appetite. So iron deficiency takes away your drive to eat. So it making it even harder for parents to get their children to eat a wider variety of foods. Milk is high in fat and it's low in fiber, and this also leads to constipation, which then further impacts appetite. Many children, even preschoolers, drink milk from baby bottles across the day. And even today, I saw a child who's 6 years old who drinks 4 bottles a day of milk. And the problem with this is, well, there's a couple problems. One, if you drink baby bottles for a prolonged period of time, it delays oral motor development. And the other is that it allows milk to lay continuously on the teeth, which causes problems with dentition. Milk is full of sugar and it's full of acid, and it strips the enamel off your teeth. And again, if children are drinking large amounts of milk, they just are not going to be hungry for eating other foods. One of the periods of time in development that's problematic is the period of time when children are transitioning from formula to milk. So infant formula and toddler formula, by and large, they're fortified with iron. So children that are drinking formula typically don't have issues with iron deficient anemia. It's only when they switch over to cow's milk, which has far less iron, that becomes a problem. In both in the literature, if you look at it, one of the big events that leads to iron deficiency anemia is switching over to milk. And the problem is that when kids just flip over from milk to from formula to milk, in some cases, they're not eating sufficient solid food. So they're not eating enough complementary foods that contain iron to provide them with the iron that they need. In many cases, when families come in and they talk about what their child's eating and their doctor has recommended them, it's time to switch over to milk, I do not recommend switching off of formula at that time until the child has learned to eat a wider variety of foods. Because if they just switch from formula to milk and don't have other foods in their diet, they're going to develop iron deficiency anemia. And very often, they'll often develop other issues because if they're eating predominantly or drinking predominantly milk and not really eating that much, we've also seen vitamin C deficiency as becoming an issue. Now, here's a couple of case studies. And in the top 3 lines in this chart, they're all essentially toddlers that are typically developing. Their weight is within the normal limits. They're taking 26 to 33 ounces of milk a day, which probably fills them up and they don't eat other foods. And these children all developed iron deficient anemia. Now the last case, the bottom row in this chart, is a 2-year-old male who's on the spectrum. His BMI is less than the first percentile, and his diet consisted of breast milk and vegetable juice only. So he didn't eat any foods. He only ate vegetable juice and then drank breast milk. Exclusive breastfeeding over the age of 1 year often leads to nutrient deficiencies because the breast milk, as the child gets older and larger, it just is not sufficient to provide the calories and nutrients that are required. So kids that are breastfeeding over the age of 1 year typically should also be eating complementary. So it's not that you don't breastfeed, it's you don't exclusively breastfeed. So that can lead to problems, and as evidenced by this case study here. In some case, and this is an example of one of the things that I think is kind of a misperception by many people. Many of the kids that we see with nutrient deficiencies are not underweight. In fact, this case here, there was a morbidly obese 4-year-old boy with autism who was referred for eating a diet that consisted mostly of ice cream and snack food. So if you're eating almost exclusively ice cream and snack food, you're probably not going to be failure to thrive. You will, however, develop nutrient deficiencies. This child's mother, who was worried about his health, would dream feed him bottles of milk at night. So as he's going to sleep, she's giving him a baby bottle full of milk. So he is taking in ice cream all day and milk all night. So he's getting huge amounts of dairy. And as a result, develops iron deficient anemia because he just doesn't have other sources of iron in his diet. So what we did was we started adding a multivitamin to bottles and eventually faded to juice with a multivitamin. We moved a meal and snack schedule, added fortified cereal, and moved from ice cream to smoothies with fruit. In this child's case, we use stimulus fading, which involves introducing or alternating a new element such as color, intensity, or size to the target stimulus, which is gradually faded by reducing its intensity or components. Typically, only one element is altered at a time. Stimulus fading we use that all the time. And in this child's case, we crushed a multivitamin. We in fact crushed a Flintstone Complete, and we put 1/4 of that multivitamin in one bottle. So across 4 bottles of milk, we spread out one multivitamin. And the reason we did that is so that the taste would be less obvious and he wouldn't reject the bottle. So I wanted him to continue taking these bottles of milk, but that had the crushed vitamin in it. So the milk in the bottles was diluted by replacing 2 ounces of milk with water each week for 2 weeks. So we're fading out some of the milk. The milk was further diluted in half of the bottles until it was water only. And then we started systematically adding juice to the water, 2 ounces each week for 2 weeks. So the goal was to get him to drink kind of a diluted juice, and then that is what we wanted to have that vitamin in. If you're going to place a multivitamin in something, don't put it in milk. We only did that because that's all the child took, but that wasn't the end of what we did. We faded it so we were going to we wanted to put the vitamin in juice. And the reason you do that is in milk, the calcium and the casein block the iron that's in the multivitamin. In juice, and we picked a juice that had vitamin C in it, the vitamin C helps absorb the iron. So I know that many families are told not to give their child juice. I think any of those things, you got to look at when pediatricians make recommendations like that, they're making it for the general public, for everybody. But in every child's case, the recommendations do not hold. We do recommend juice at times because in some children that we see, juice is their only vitamin C source. And since there's vitamin C in the juice, then we want the vitamin in there so the child's able to absorb it better. But this is just an example of how we use fading to make changes in multiple ways, and it's a highly effective tool. We probably use stimulus fading more than any other behavioral tool, even reinforcement. Another example of fading, it was underweight Andy. He was a 17-year-old boy who was on the spectrum. He was been hospitalized on several occasions for dehydration. He had a very narrow diet and would often go on food jags. His BMI was below the first percentile. And when we first met with him, he was drinking 4 to 8 6-ounce bottles of apple juice daily, and all of them were diluted with water. So he was drinking a lot of watered down apple juice. We suggested 4 structured meals per day, 4 foods at each meal, and no food more than once per day. So we wanted to rotate through foods to avoid the food jags. And we started taking Boost Breeze, and Boost Breeze is a supplement that comes in the form of a juice. It's high in caloric density, it's 30 calories an ounce. So we systematically added that to the diluted juice. So it would be 3 ounces of juice, 2.5 ounces of water, and 1/2 ounce of Boost Breeze. And each week we replaced 1/2 ounce of water with Boost Breeze and stopped at 2 ounces of Boost Breeze per cup. And by doing this across the course of the day, he was able to take a box of Boost Breeze, which is, they're 8 ounces. So he was able to get 8 ounces in. So he got several hundred calories from that supplement, which increased his overall caloric intake, which allowed him to grow at a faster rate. We put all the drinks in a colored cup with a lid and a straw and not in the original container. And that way, all the changes that we were making, he wouldn't be able to detect based on their color. I mean, certainly the taste would be a little bit different, but we also were doing these changes slowly, only 1/2 ounce at a time. So hopefully across the course of time, he would be able to adapt to these changes and drink his juice, and he did. In terms of addressing iron deficiency anemia, what kind of things can you do? Well, for many children, reduce milk consumption, and this can occur in several ways: offering bottles only at meals and not in between meals, diluting the milk, especially at bedtime, placing less milk in the bottle, and offering other fluids if possible, especially juice with vitamin C. Certainly we want kids to drink water, but we're trying to figure out, what is your goal? If you've got a child that's iron deficient, you do probably want to try to get them to drink some juice just so you can get the vitamin C in. We try to increase consumption of iron fortified foods. In our experience, one of the easiest ways of getting kids to take iron is not teaching them to eat liver. It's teaching them to eat iron fortified cereals. So there's a number of different cereals like multigrain Cheerios, Special K, Product 19, all those types of things that are fortified with iron. And we've always had a little bit more luck getting kids to eat that than other foods. Getting children to eat more meat, even baby food meat mixed with other foods, can increase iron. Meat is certainly a good source of iron. Or you can use vitamins or iron drops. Iron drops are not tasty. So in some cases, you do need to work on fading, because that does take, if you just put the entire dose of iron in a little bit of juice or something, that may not go over very well, because it smells and it tastes pretty bad. Whenever possible, we try to pair iron-rich foods with foods containing vitamin C and not dairy, so that the vitamin C increases the absorption of the iron. That, by the way, that when you pair these two foods together to increase the effectiveness of some vitamin or some other aspect of the food, they call that food synergy. And that when we always try to look at, can we do that when we're talking about diet recommendations? One of the interventions that we use pretty commonly in our clinic is called Plate A, Plate B. And I just want to at least give you an overview. So as we talk about that in different cases, then you'll understand what I'm talking about. In Plate A, Plate B, the child is offered novel foods. So there's a plate, and the plate contains little tiny specks of new food, the size of a grain of rice or a pea. And contingent on tasting these foods is provided a bite of familiar food and a preferred drink. So they've got 2 plates. We typically use 2 plates. You don't have to, but one plate would contain the novel foods. The other plate contains much larger pieces of preferred foods or familiar foods, and you have a preferred beverage. So I tell parents and I tell children, this is a 2-for-1 deal. You take one little taste of this and you get 2 things you win. You get your preferred food and you get your preferred drink. tasting is required to gain access to the familiar foods, but only tiny tastes are required. Because what we know about taste exposure is that only tiny tastes are required to develop taste preferences. At any particular meal, nothing is required, but access to familiar foods is contingent on tasting. So if they don't eat at a particular meal, that's okay. We wait and do it again later. And what do we hope? Motivating operations will help us. So this is a use of sequential presentation, and that's well established in the literature. So this is a intervention that combines both fading and reinforcement, because we use these little tiny tastes of food initially, but as a child gets familiar with a particular food, so they've eaten pears a number of times and they're not having any issue with it, you can make the bites bigger. And I'll give you an example here. There are 4 plates here. The 2 plates on the bottom, the blue plates, are the target foods. So on the lighter blue plate on the left, there's little tiny bites. And these bites could have even been smaller. And the plate on the left, or the plate on the right, the darker blue plate, has larger pieces of target food. So as the children eat the smaller ones and are having no problem, you can make the bites bigger. And the same goes for the reinforcer. So you've got the green plate, which has pretty big pieces of cinnamon swirl bread, and it's got entire stick pretzels. It's got some M&Ms there, some goldfish, but the pink plate on the right has little tiny snivels of pretzel. So as the child's getting better, you can decrease the magnitude of the reinforcement from a big piece of bread to a little snivel of pretzel, based on the progress of the child, of course. A recent case of iron deficiency anemia that we worked with was an 11-year-old boy who had trisomy 21, and he also had autism spectrum disorder. He was admitted to our day treatment program for a selective diet. His diet consisted of fig Newtons, chips, pretzels, vanilla ice cream, milk, and occasionally juice, but not very occasionally. He refused all fruits, vegetables, meats, cereals, and a multivitamin. He was hospitalized in March of last year for lethargy and diagnosed with iron deficiency anemia, and he was started on iron infusions. Pretty typically, the kids that are hospitalized for iron deficiency are given iron infusions because you can get the iron in much quicker, and it's better absorbed than if you just take an iron drops. So you can resolve the iron deficiency much quicker. He also had deficiencies in vitamin C and D, and the treatment options that were suggested were either a gastrostomy tube or intensive treatment to change his diet. In our baseline meals, he refused to taste any new foods. We started with some plate A, plate B meals, and he refused to taste any new foods. So on day 2, we changed our treatment and we conducted 8 sessions and used non-removal of the spoon. So we just held that spoon there until he took a bite. He consumed 1 to 7 bites a meal. In the evening at home, he ate both applesauce and chicken nuggets, which he had not previously eaten. So we considered that a win. Now on day 3, we changed to exit criterion, and we started exit criterion with a 54-minute meal that I just sat there and waited till he took a bite. And we'll talk about that protocol a little bit later. But we did get him to eat a wider variety of foods. And I'll just give you an example of an exit criterion meal at the clinic, not the 54-minute meal that we did at first. So he takes his little bite, he's given his iPad and a bowl with a couple little treats in it, and he's out the room. In 18 days, he learned to eat peaches, pears, oranges, pineapples, mixed fruits, carrots, applesauce, sweet potatoes, ham, chicken, cream of wheat, yogurt, and spaghetti. So you can see the focus is on, we focused on foods that contain vitamin C, and we can focus on some ham, chicken, and cream of wheat are all foods that contain iron. We worked on having him learn to drink a range of juices, including several types of B8 Splash, and his juice is where we place the multivitamin with iron. So his dairy consumption was limited to 2 servings per day, and the focus of treatment was to ensure he would consume a diet that would preclude any future nutritional deficiencies. When he came back in at 1 month follow-up, he continued to eat the foods that he had added during day treatment, and he'd also added, I think he'd eaten cream of wheat before, but he learned to eat sausage additionally. Endocrinology suggested increasing dairy to 3 servings a day to increase vitamin D, but we kept him at 2 servings of dairy, but we also gave vitamin D fortified orange juice to try to get that extra serving of vitamin D. And the family continued to work on increasing diet variety, and he continues to do well. One final word about the milk. Dairy alternatives such as soy milk, almond milk, etc., often contain calcium. In fact, very often more calcium than cow's milk. So just switching away from cow's milk does not preclude the development of iron deficiency. So it is true that excessive consumption of cow's milk does cause iron deficiency, but excessive consumption of other things also does too. We recently saw a child who was drinking soy milk secondary to a cow's milk protein allergy. He was iron deficient, and the parents were told soy milk would not result in iron deficiency. That just is not true. If you take in a lot of soy milk, but you're still not taking in iron from other foods, you're going to develop an iron deficiency just as you would if you were drinking too much cow's milk. When you hear the word scurvy, you think about pirates in the 18th century, but it's becoming more common. If you look from 2000 to 2019, and certainly I've been tracking the literature, there's a number of studies that have come out this year as well. The number of studies is pretty steady across the last 2 decades, and the number of patients is continuing to climb. In fact, it seems like it's climbing a little bit more. And over the last couple of years, the number of studies have trended upward. If you look back earlier than 2000, they've certainly had case studies on scurvy, but not nearly as many. So scurvy is not something that's unheard of. It's fairly becoming more and more commonly reported. What is scurvy? Scurvy is a disease that's caused by a vitamin C deficiency. Vitamin C, or ascorbic acid, helps maintain intracellular connective tissue, serves as an antioxidant, and assists in the synthesis of dopamine, norepinephrine, and epinephrine. Just as importantly, it aids in the absorption of iron, and that's one of its more important roles. If you don't take enough vitamin C, it's very hard to take in enough iron. Scurvy is the oldest recognized nutritional deficiency, and it was known to the ancient Egyptians. So this has been around for a long, long time, and people certainly recognize, we didn't always know what caused it, but we knew, what it was. 8 to 12 weeks of inadequate intake of vitamin C can result in clinical symptoms. So it doesn't take a relatively long time to develop the signs and symptoms of scurvy. We've published a couple articles that have talked about children with vitamin C deficiencies, and we looked at the literature and we found only the literature back to 2000. We found 77 children, just children, who were diagnosed with scurvy. of these 77 children, 25, all males, were on the autism spectrum disorder. When you looked at just the ones that had scurvy as a result of selective eating, 24 of those, or there was 59 children and 24 of them had autism spectrum. So a fairly high percentage, given that autism spectrum is not as large in the general population as kids without autism or kids with other special needs. We've even seen a few kids at Hershey over the years that developed scurvy. They weren't selective eaters, but they were infants and their parents were giving them a blended diet for their G-tubes, and they cook the diet. So if you cook fruit, it cooks out the vitamin C. So that the children got scurvy because their diet didn't contain vitamin C, just because it was, not because anybody tried to delete it, it just got cooked off when the family was making their tube feeds. Where do you find vitamin C in the diet? Well, it is in breast milk, it's in infant formula, it's in cow's milk, but there's very little in cow's milk. It is found in fruits, especially citrus fruits, oranges, lemons, limes, grapefruits, but it's also in gooseberry, black currants, melons. Applesauce, apples do not have very much in the form of an apple, but in applesauce, they add vitamin C or ascorbic acid because ascorbic acid is a preservative. And this is why McDonald's apple slices never turn brown. Like if you see them in these little bags and they're always, look white like they just got cut, and you tear them open and they don't seem to turn brown as they sit there on the table, that's because they've been treated with ascorbic acid. So I don't know what the vitamin C content is of a McDonald's apple slice, but my bet is it's pretty good. There are vegetables that also contain vitamin C, especially tomatoes. And there's some in potatoes and green chilies and cabbage and broccoli and spinach. So there's a number of fruits and vegetables that contain vitamin C. And those are probably the biggest sources for vitamin C is fruits and vegetables. It's typically added to fruit juice. So even apple juice, which doesn't have very much vitamin C in it from the apple, gets vitamin C in it. It may also be added to other foods. I've seen it added to fruit snacks. I've seen it added to breakfast bars. A couple of years ago, some of the soda companies were adding vitamin C, but then they stopped after the huge outcry because people were worried that kids would start drinking soda instead of even juice. Now, this chart shows the clinical spectrum of scurvy from the earliest symptoms that you would get to the later manifestations that you get. And early irritability, appetite loss, fever, petechia, and dermatological signs. And then finally, psychological changes, poor wound healing, and death. They've got limb swelling and limp and joint swelling, kind of in the middle. And I think we have pretty good evidence that this is not true. We found leg pain is perhaps one of the earlier signs, and in some children, the earliest signs, even before you start to get petechia and before you get any kind of other dermatological signs. And I think that's not, we just published an article about that, and I think that's not broadly known in the literature. This is a little boy who's got scurvy, and you do very often see kids that sit with their legs pulled up, and what they're trying to do is not bend their knees and their hips because that causes pain. Because if you don't have vitamin C, it starts to break down your joints, and eventually it'll break down your bones. These are petechia. So they get these little tiny red papules on the, it's usually on your arms and legs. You can have them on your trunk as well, but these little tiny red dots will be there. So that's another sign, often a fairly early sign of scurvy. And if you look at this little boy's heel, you see all this purple. That's because there's blood leakage. So that's blood that's gathering around the bottoms or below his ankles. So it's leaking out of the joints. And in this picture, this child, they're looking at her gums, and you can see how red it is right above the teeth. So you're in scurvy, you get very often your gums will bleed and they'll be red and swollen like this child's are. Now, in our recent study, 2 of the children we looked at, there was a 5-year-old boy with autism spectrum disorders. That young man ate McDonald's chicken nuggets, Kit Kats, and milk, and that was it, nothing else. And he did not take any kind of vitamin supplementation. He was admitted for iron deficiency. He was discharged on iron drops, and his mother reported leg pain to his primary care provider, who referred him to physical therapy. That did not resolve the leg pain. In fact, that made it worse because he was exercising more. We saw him and we got lab work done, and he had a vitamin C deficiency. The leg pain resolved within 2 weeks of starting on vitamin C. So we had vitamin C added to the milk, and eventually started working on adding other things. We saw a 9-year-old boy with ADHD who only drank water and 1 glass of milk daily. He ate only snack food, no meats, no fruits, no vegetables, and was reporting leg pain. And we got his, asked the PCP to run lab work, and he also had a vitamin C deficiency. The multivitamin was added to his milk, and the leg pain resolved in about a week. So these manifestations of vitamin C deficiency resolve pretty quickly as soon as the kid starts getting adequate vitamin C. So these things do resolve, the leg pain and the bleeding and the petechia and the swelling of the gums. All that gets better after you start getting vitamin C. And it doesn't take very long. About 2 years ago now, 3 years ago, we saw a 5-year-old girl with typical development who presented to the emergency department for leg pain. She had recurring photosensitivity. She had fine scale on her trunk, so this dried skin on her trunk and extremities, and these small pink flat papules on her lower leg, just like that picture I showed. She was evaluated by several times over different 3 weeks by dermatology, rheumatology, orthopedics saw her. The rheumatologist ordered vitamin C level, and it was so low it was almost undetectable. It was less than 5 micromoles when the normal range is 23 to 114. Her prealbumin, ferritin, and iron saturation were all low. So she was also low in iron at that point. Her vitamin A and D were within the normal range. But at 1 year of age, this little girl transitioned from formula to milk and puffs. So she only ate 2 foods for a while, which was milk and puffs. Her diet did expand, but expanded only to include Ritz crackers, skim milk, chocolate pudding, banana, chocolate, vanilla ice cream, and soda. When we saw her, her BMI was less than the first percentile, and her mom carried around because she couldn't walk. Now, when we did this child's treatment, this is something interesting we learned. We used repeated taste exposure with her to get her to taste new foods. But when we did that, we selected 12 foods, and we randomly assigned them to 3 different groups. So in group 1, we had foods that we offered for 3 or 4 sessions in a row. And And for group 2, we did offered to 1 of 4 sessions, and group 3, we never offered them at the taste sessions, only probe meals. So in all these, for these foods, we would offer them in taste sessions, or in case of group 3, not at all. And then after so many taste sessions, we would do a probe meal. And in the probe meal, we just offered these foods. And if the child ate them, she ate them. If she didn't, she didn't. We just wanted to see what she would do. And what we found is in the probe meals, where she was not required to take any particular food or any food at all, she took mostly bites from group 1, some bites from group 2, but never from group 3. So it just showed you the kind of the power of repeated exposure. And that's, we hadn't, nobody had shown that before. So we thought that was important, that we realized that we really do need to taste these foods if you expect that child to learn to like them. Now this is this little girl, and here's just a couple little clips across the course of her treatments.
You don't. That's applesauce. But I hate that apples.
In these 3 clips, the initial clip was baseline, where she said, of course, that she didn't wish to eat anything. In the second little clip, she took a bite of food. That was her doing an exit criterion, repeated taste exposure and exit criterion. And here we had switched it over. She was tasting foods and doing pretty good, so we had switched it over to plate A, plate B. And she started eating these pretty decent little variety of foods. Now, this is her growth chart. And you can see at the very bottom, when we initially started, she was off the bottom of the growth chart, and her gains in weight over the span of several months went up almost vertically, to the point where her last point, she was at her BMI was at the 85th percentile. So we were able to correct her, and this is her BMI. So this isn't just her weight. So not only did we get her to gain weight, but we got her to increase her proportionality. So she did quite well after she learned to eat a variety of foods. Because as you correct some of these nutrient deficiencies, you probably feel a lot better. She was able to walk, and as we corrected the iron deficiency, she was probably hungrier and more motivated to eat a wider variety of foods. One of the things that you see in kids with nutrient deficiencies, and including the little girl we just talked about, was comorbid deficiencies. So very often you see deficiencies in iron and vitamin C, and sometimes you'll see deficiencies in both C and D. And here's an example. There's a 12-year-old boy with autism. He was referred for limited diet and obesity. He consumed Fruit Loops, goldfish, cola, chicken nuggets, fries, and pizza. He was referred to orthopedics and rheumatology for hip pain, and he was treated for chronic osteitis. So they thought he had this rheumatological problem, and they thought about scurvy. It was in their differential diagnosis, but they didn't believe he had scurvy because he had no cutaneous symptoms. So he didn't have the petechia, he didn't have bleeding gums or any of those things. He just had this hip pain. And they did later run lab work and found out that he had deficiencies in both C and D. He improved with his ability to function and walk and move after he started receiving vitamin C. And when we saw him, we moved him we added multigrain Cheerios to Fruit Loops, and then gradually replaced more and more of the Fruit Loops with multigrain Cheerios. We systematically replaced cola with Diet Cola. So we were getting rid of some of the extra sugar and calories so he'd be motivated to eat more. And we used plate A, plate B to introduce new foods with goldfish and fries on plate B. So we worked on getting him to eat a wider variety of foods. And specifically, we try to work on foods that would address the child's nutrient deficiency. So if we have children with scurvy or a vitamin C deficiency, you do see us working on fruit a lot, or other foods that contain vitamin C to try to directly address that issue. Okay, and at this point, we'll take a break for just a moment. There are a number of different B vitamins, and the ones that we talk about, B1, B2, B3, B5, B6, B7, B8, B9, and B12. The ones that you hear about most, probably B12, and some of the other ones you don't really hear that much about. You don't hear about why they're important, why they're not important, and what some of the issues were in the past. And you don't necessarily hear about it because in the United States, we have a food fortification program. So some of these B vitamins are added to your food, and have been for 70 years. Now, sources of B vitamins: whole grains, meat, egg, dairy products, legumes like beans and lentils, seeds and nuts, dark leafy vegetables like broccoli, spinach, fruits, citrus fruits, avocados, bananas all have different B vitamins in it. Why are some B vitamin deficiencies rare? Well, in 1928, about 7,000 people died of pellagra in the US. Across the 1930s, the links between vitamin deficiencies and disease were finally confirmed. So a lot of people died of this disease, pellagra, but nobody knew why. Initially, we thought it was an infectious disease, like a virus or a bacteria. We didn't understand that it was due to a nutrient deficiency. And that's the same that some of you have probably heard of a disease called beriberi. That's a thiamine deficiency, but we didn't know that at the time either. And for decades, we didn't know, or hundreds of years, in fact, we didn't know what caused it. We just knew there was a problem. The fortification of milk and flour became necessary because when they were recruiting young men to enlist in the military, particularly right before World War II and during World War II, a lot of them had poor nutrition. A lot of the young men and young women that enlisted were poor and did not have access to a wide range of foods. And as a result, they started adding food or adding nutrients to foods. So they would add vitamin D to milk. to prevent rickets. Vitamin B1, thiamine, and niacin, and riboflavin and iron were all added to flour to address the prevalent health conditions like beriberi and pellagra. And to this day, you still have some of these things. Like you hear about iodized salt. Well, they add iodine to some salt. And fortified flour is used in the manufacture of starches, snacks, processed foods. So it's pretty rare to have kids with pellagra. I've only seen this one child with pellagra that I'll tell you about, but I've not seen a lot of other kids with deficiencies in thiamine or deficiencies in riboflavin. They can occur, but they're so rare I've never seen them. Now, primary pellagra is the result of a niacin deficiency. It was once the 8th leading cause of death in the United States. It was prevalent in the Cotton Belt in North Carolina, South Carolina, Georgia, and Alabama. The 4 Ds of pellagra are diarrhea, dermatitis, dementia, and death. It was virtually eliminated in the US due to the fortification of grains with free niacin. So as they added niacin to grain, pellagra went away. But even throughout the South, they had pellagra hospitals where they took care of persons that had what they called pellagrins. You occasionally see pellagra now in alcoholics, persons with anorexia nervosa, persons with Hartnup disease, which is a metabolic disorder. But otherwise, it's pretty rare. You will have outbreaks of pellagra in areas where there's famine and war. They've had a couple of outbreaks of pellagra in the last couple of decades in parts of Africa and in the Middle East. But otherwise, I don't think you don't even hear about it in the United States. We saw a 10-year-old boy with autism who presented with a blistering rash on his hands, forearms, neck, and feet. Initially, he was treated for cellulitis. His rash subsided and then flared again. He was diagnosed with pellagra by pediatric dermatology. His diet consisted of a few fruits and vegetables, but no meats, no eggs, or no grains. So he didn't have access to niacin in his diet. His weight was at the 60th percentile and his height was at the 65th percentile. We added a multivitamin to his Gatorade. The consumption of fortified cereal was rewarded with access to preferred foods and his tablet. So we did these kind of like a taste session, and a combination taste session and plate A, plate B session to get him to eat fortified cereal. And we did other taste sessions, which would we would introduce new foods and reward with contingent access to his tablet. So the tablet was his big reinforcer. So we did use that contingently to work on getting him to eat a wider variety of foods. This is this child's forearms. And you can see this really, really dark, it looks like a horrible sunburn. And the picture on the right is the back of his neck. So this is, and it looks like he's been scorched by the sun. So these are hallmarks of pellagra. Let me get to the there's always some type of technical difficulty, and this is mine. In follow-up at 2 months, we saw him and all his symptoms had resolved. So the rash around his neck and his arms had all gone. He continued to make gains in weight and height. He now ate multigrain Cheerios, which have B vitamins and iron. He drank V8 Splash and 16 ounces a day. So that had vitamins A and C. He drank orange juice fortified with vitamin D. And we used plate A, plate B at home and school. And we reduced his grazing of snack foods all day so that he'd be more motivated to eat some of the foods we were offering in plate A, plate B meals. These are other examples of pellagra. You can see this child's hands, how it looks like he's been scorched or burned. And the child on the right, there's like this pattern around their neck. They call that Cassell's necklace, named after the first person that came up with the name pellagra. Now, I just talked about taste sessions with this young man that had pellagra. And in taste sessions, they involve having the child taste a small taste of food, and then they receive some type of incentive or reinforcer for tasting. The taste sessions are time limited, typically 5 to 10 minutes long, and consist of the following components. There's appetite enhancement. So in this young man's case, we didn't let him snack all day long. Reinforcer selection and criterion. So this child wanted to spend as much time as he possibly could on his tablet, so we used the tablet contingently. So when he would take bites of the target foods, he would get access to this tablet for a period of time. We used planned ignoring, so when he exhibited inappropriate behaviors during sessions, they were just ignored. In his sessions, we did use choice. So he had a couple different things he could select from, and if he took a little bite of any of the foods on that plate, then he could have access to the tablet. And we used repeated exposure. We kept having him taste these things over and over and over, because we know that if you want to develop a preference for a novel food, you have to taste it repeatedly over time. And I absolutely talk to parents about, if your child tastes a particular food and they may gag or they may spit it out or they may tell you that it's disgusting, what does that mean? Nothing. It really, in order to learn a preference for a food, they have to taste it repeatedly over time. They don't have to eat the whole plate of that food. They don't have to eat a large portion. The dose does not matter. It can be a speck. It can be a grain of rice-sized piece. The more important thing is tasting it repeatedly over time. How can these taste sessions help? Well, it gives you a mechanism for introducing new foods or drinks or vitamins or supplements. They can be implemented away from meals or instead of meals. So it's not uncommon for us to have taste sessions implemented by persons other than family members. So if you've got a BCBA or a aide at school or somebody who has pretty good instructional control and works well with the child, they can do taste sessions to introduce a particular food. And then perhaps later the family can introduce that food in the home. So it makes it a lot easier for the parents. It doesn't mean the parents can't do taste sessions. It just means that they don't have to be the only ones that work on this feeding issue. Now, here's just a couple examples of vitamin B deficiencies from the literature, just some case studies. There's not too many. Pretty rare was an 11-month-old that had a vitamin B6 deficiency, a little child without autism, and ended up with, had liver dysfunction. There's one child that had a B3 deficiency that had dermatitis, 11-year-old female. So these are typically kids with just selective diets that had these issues. The biggest one you see, though, is not B3 or B6, it's B12. And many of these kids, some of them are younger. There's several that are infants. In fact, many of these cases are infants. And in these cases, more typically, they're infants whose mom was on a vegetarian diet and the child was breastfed and they didn't get B12 from their mother because the mother didn't pass B12 through the breast milk. There are a couple of kids with autism who didn't, probably ate a diet predominantly of snack food, who didn't get B12 in their diet and ended up with visual impairments. Since B12 is mainly found in meat and eggs and dairy products, some vegetarians, as I just mentioned, are at risk of developing a deficiency. Multiple cases of B12 deficiency are documented in infants breastfed by vegetarian mothers, and I just showed you a couple. You probably see children that have gastroesophageal reflux taking protein pump inhibitors, which is omeprazole, Prilosec, Prevacid, Nexium. All those are what we call protein pump inhibitors that block the production of acid. That can increase the risk of a vitamin B12 deficiency because vitamin B12, it requires gastric acid to cleave the vitamin off of the dietary protein. So it requires the stomach acid to break down the food so that vitamin gets released. And if you're taking protein pump inhibitors, the whole point of the protein pump inhibitors is to block the production of acid. So I've not seen it. I've seen thousands of kids probably that were taking medications for reflux, but I've not seen any of them that resulted in B12. They have had a couple of cases reported, but I've not seen it personally. Unlike other B vitamins, B12 is not routinely added to grains, so children that eat primarily snack foods and drink soda or juice are at risk for having a B12 deficiency. And we have seen a couple in our clinic, but that's less typical than some of the other things we see. Now, what should you know about vitamin A? Well, vitamin A is required for the integrity of all surface tissues, including skin, inside the respiratory tract and the bladder. It's required for cell replacement. Vitamin A is essential for vision. It's a leading cause of preventable blindness in the world. So all through Southeast Asia, there are children that have problems with vision secondary to not getting enough vitamin A. So in some countries, their food fortification programs focus on increasing vitamin A to prevent blindness. Xerophthalmia, that's a spectrum of ophthalmologic disease caused by vitamin A deficiency, and it's characterized by dryness of the cornea and conjunctiva. So your eyes essentially dry out from the vitamin A deficiency, and very often, let me show you, there's different types of xerophthalmia. Night blindness is one. You get corneal ulcerations, you get corneal scarring, so you get different problems with your eye. And I'll give you a couple of examples just so you can see what this looks like. If you look into this eye, it's kind of cloudy looking, and it's starting to, the surface of the eye is starting to harden. And in this one, it's a little more clear. You can see to the left of the iris, you can see this white spot, and it's a corneal ulcer. So as these things start to form, it impacts vision and eventually leads to blindness. This is something that I thought was particularly interesting. I was looking up all these different vitamin deficiencies. I was looking at the case studies and trying to find out who were they looking at. And for vitamin A deficiency, I found, and I looked back past the earliest one I found was 1998. I looked just for children, and I was looking at case examples of vitamin A deficiency secondary to selective eating. And in all but 2 of these cases, so 12 out of 14 cases, there are children that are on the spectrum. And almost all, like in many of these cases, there's a couple there that the children are eating Pop-Tarts and soda, Pop-Tarts and water. They talk about breakfast pastries, so they're just not getting any source of vitamin A in their diet. Sources of vitamin A in the US, milk is fortified, so you can get it from milk. You can also get it from broccoli and fish and meat and eggs and cheese and avocados and peppers. So there's a variety of different foods, but many of these foods are not ones that all children eat. Marini and colleagues reported a case of a 5-year-old girl with typical development who consumed almost exclusively oat milk for 2 years. Despite treatment for the vitamin A deficiency, she had permanent bilateral visual impairment. If you're drinking a diet that consists primarily of any form of milk, whether cow's milk or oat milk or some other form of milk, it's not going to be balanced. If you're not drinking, if it's almost all cow's milk, you're going to get an iron deficiency and probably a vitamin C deficiency. In this case, this young lady was drinking the oat milk and ended up with a vitamin A deficiency. I suspect she probably had other deficiencies as well, but they didn't mention them. That said, oat milk does not contain vitamin A, and it's not an equal substitute for breast milk or cow's milk. So the point is just to think of the nutrient content of these foods. So if you want to switch away from cow's milk, you got to know what's in that milk and what are the other items that are in the diet. So like if you don't want to drink cow's milk, where are you going to get vitamin A? Where are you going to get vitamin D? Where are you going to get calcium? So where are you going to get protein? So where are you going to get the foods? If you take a food out, what are the substitutes in the diet for that food? We saw a young man. It was a 10-year-old boy with autism spectrum disorder who was referred for vision problems. He was diagnosed with idiopathic intracranial hypertension, which just means there's intracranial pressure with no identifiable cause. And that's often seen in vitamin A deficiency. His diagnosis could have been caused by things other than a nutritional deficiency, so it took a little while to chase down the fact that it was vitamin A deficiency. His diet consisted of iced tea and a few snack foods. He was given infusions of vitamins to address the vitamin A deficiency. I saw him one time. I attempted to give him a little taste of some food. He vomited. And never returned for follow-up. So his mother, I talked to her later, and she said he just couldn't eat any other foods and opted for just vitamin infusions to address his deficiencies. I'm not sure whatever, I mean, he's not cared for at our facility anymore, so I'm not sure what happened, but I'm hoping he did expand his diet. Why do you need vitamin D? Well, vitamin D plays a role in calcium and phosphorus metabolism. It's most famously known for its role in bone health. It also does affect extraskeletal tissues like the brain and the heart and skin. The main source of vitamin D is not the food you eat, but it's sun exposure. Children, especially infants, need less sun than adults because they are better able to produce vitamin D and their surface to size area is greater. For those of you that are adults, if you sit outside and eat your lunch and you have your head exposed and don't have suntan lotion on and you have short sleeves, by the time you finish your lunch, you should get enough vitamin D for the day, just from the sun. Kids are a little quicker. They can get it a little more readily, and little kids that are running around playing outside typically some of the kids that come in that are tan and they spend time in the pool, I know they don't have a vitamin D deficiency. Now, if you look at the left picture, that little boy is bow-legged. And if you look at the picture on the right, that child is knock-kneed. And both of those are a result of rickets from vitamin D deficiency. So in vitamin D deficiency, the bones get weak and soften, and then they can get, they bend. So instead of having straight legs, they're either bent in or bent out. Vitamin D is found in oily fish, cod liver oil, egg yolks, liver and organ meat, and some mushrooms, all things that no children eat. So in the US, they fortify milk with 100 international units per cup. So most plant milk alternatives are also contain vitamin C. So like soy milk or almond milk or whatever, they typically do put vitamin D in there as well. In this chart is just a comparison of unflavored milk alternatives for different nutrients. And I wanted to show you that cow's milk has more vitamin D than any of the other alternatives, and about a quarter more than most. It has more, a lot more protein than most, and it also doesn't have as much calcium. They have a lot of calcium in like almond milk, but it certainly has adequate calcium, and the calories are typically higher, so you get more energy per cup. So that's just how it stacks up in terms of the vitamin D. And vitamin D deficiency, the biggest issues are typically rickets and osteomalacia, which is a softening of the bones. It can lead to fractures. So kids that have vitamin D deficiency often are at risk for fractures. It also it results in exacerbation of asthma, atopic dermatitis, inflammatory bowel disease, and Crohn's disease. So some of these inflammatory issues can be worsened by the vitamin D deficiency. It increases the risk of elevated blood glucose levels, hypertension, and metabolic syndrome. So vitamin D deficiency does make, if you're overweight, it makes things worse. And vitamin D deficiency is associated with overweight and obesity. This is a quote from, I'm pretty sure it's from the New England Journal of Medicine. Hypovitaminosis D, which is the vitamin D deficiency, is widespread and represents a reemerging global health problem. In childhood and adolescence, low vitamin D is mostly due to unbalanced diet, especially in adolescence when adolescents are consuming more fast food and junk food and drinking soda instead of milk. So the diet is much more of a risk factor. Another risk factor is a sedentary lifestyle due to the increased screen time. Even though the screens may be bright, you can't get vitamin D from them like you do the sun. So if you spend all your time inside on a screen and not outside in the sunlight, it increases both the probability of obesity, but also the risk of a vitamin D deficiency. In one case study, a 15-year-old boy with autism presented with leg pain and difficulty walking. His diet consisted largely of potato chips and gravy. and refused all dairy products. He seldom went outside, and laboratory findings showed almost undetectable levels of vitamin D and calcium. He was provided with vitamin D supplementation as well as multivitamins, and in 6 months there was no problems with ambulation and no reported pain. So again, these things can go away when children receive the appropriate diet. If you look at the picture on the right, there's a little boy's hand, and it is very orange. That's because this little boy drinks 2.5 liters of carrot juice daily, and his diet consisted of chocolate, battered chicken breast, dry bread, and wafers. The orange is not from the deficiencies, it's from an excess of beta carotene, but he was deficient in both vitamin A and vitamin D. This child was still largely asymptomatic, but if he would have continued on that diet over time, that would have been problematic. He would not have gotten enough vitamin D, and it probably would have affected bone growth. In another case study, there was a child from New York City who unfortunately ate no fruit and nothing other than crackers, ice cream, and water. It was a 5-year-old boy with autism who had always had a limited diet, but restricted to 2 foods for almost a year. He had both scurvy and rickets. There's just another example of comorbid nutrient deficiencies. So when you see children that have diets that are this limited, that are really just eating crackers and ice cream and water, they really need a nutritional assessment, and quite possibly blood work or further workup, but at least have an assessment to find out what's going on and where things are missing and whether they need change in diet or at least some kind of supplementation with vitamins to prevent deficiencies. There's been a number of research studies that have looked at vitamin D levels and vitamin D deficiency, more specifically in children that are overweight and obese. And they found out that in kids that are healthy weight, the probability of a vitamin D deficiency is about 21%. In children that are severely obese, it goes up to about 49%. So your weight status can affect whether you're vitamin D deficient or not. And certainly the diet of persons that are, it certainly is related to diet as well, but weight status is also a factor. Another factor is skin coloration. Skin coloration affects the body's ability to convert cholesterol to vitamin D. So kids that are African American, whose skin is darker, it increases the probability they're going to have problems with vitamin D absorption. So the African American children are more likely to be vitamin D deficient, as are some Latino children, and white children are less likely because of that coloration issue. I've talked to you a little bit about repeated taste exposure and exit criterion, and mentioned it with the little girl that we had in our clinic, the 5-year-old who had scurvy. This is the intervention we use most often with our reluctant selective eaters. Without question, it's been more successful than any of the other interventions we've used with the most difficult children. But it is not easy to use because it requires the use of extinction. You essentially present them a little tiny bite and just wait, and sometimes wait a little bit more. We've published 4 articles which have demonstrated successful outcomes for this intervention. And we have used this with children with nutrient deficiencies, including 2 that we've talked about here tonight. And we've used it also to introduce new foods and ensure vitamin intake. So we've used it with children to get them to take their multivitamins in a couple of cases. The basics of this intervention were we eliminate grazing, again, to try to increase appetite. We use single bite exposure sessions. So the session only consists of one tiny little bite. They take one other bite and they're absolutely done. We use food choice. So in some cases we use food choice. So if we're trying to get them to take a multivitamin, that's the choice. They're take the multivitamin. In other cases, they may have two different fruits and they get to pick one that they want to taste at that time, and then they're done. We use structured meals, so we'll do the taste sessions, and then at the meals we'll be offering specific foods, but they don't get to eat across the course of the day outside of the sessions and outside of meals. We also incorporate fading into this intervention. So we often start with little tiny tastes and then gradually make the size of the bite bigger as we progress. Now, one of the things I want to talk about is, like, what are we doing in terms of screening for these nutrient deficiencies? Well, typically the process involves a couple of steps. One of the things we want to do is find out, what does the child drink? What are the types and the volumes of the liquids they consume every day? Then we look at, what are the foods that they're going to consume? Like, what is the variety of foods? During the appointment, the therapist will ask about the child's kind of meal and snack plan and examples of foods eaten, and then have probing questions about what's the volume of food eaten at these meals and snacks. We ask questions about vitamin use, supplement use, servings of specific food types to examine adequacy of intake. And we finally ask questions about common nutrient deficiencies. And I'll go through exactly what we do. Now, there's copies of this in the handout, so you don't worry if you can't see some of these things. So this is an example of the kind of our assessment of liquids. So we ask, what kind of milk does your child usually drink? Whole, 2%, 1%, skim, soy, rice, almond. And then how much milk or milk alternative does your child drink a day? Which supplement does your child drink and how many ounces? Which, how much 100% juice do they drink? How many other fruit juices like high C Kool-Aid do they drink in a day? Do they drink other soda or iced tea? How much water does your child drink per day? So we really want to get an idea of how much they're taking in, because we do see kids that drink far too much milk or in some cases too much juice, and those are kind of things that we want to know. This is our, what we call our food preference inventory, and it just asks, does your child eat at least 1 tablespoon of the following foods? Not every day, but would they, if presented with that food, would they eat a tablespoon of that food? And they just check that box. And it asks things, a number of fruits, a number of vegetables. They've got snack food on there. There's proteins on there, including nuts and seeds. There's a range of starches, and there's blanks there for parents to fill in different foods that aren't on that list. And again, we're looking to see, does the child eat any fruits? Do they eat any vegetables? How many proteins do they have? We specifically ask whether they take a multivitamin or a vitamin supplement on most days. Do they drink at least 8 ounces of formula or a supplement daily? And then we ask about fruit or fruit juice and vegetables and meats, and like trying to get a better idea. Do they take kind of a minimum that would protect them from developing a deficiency? We ask specifically about foods that would contain iron, like, does your child eat an iron fortified cereal on most days? Does your child eat baby cereal or cream of wheat, which contain iron? Does your child eat more than 4 servings of dairy or dairy substitutes on most days. So we're trying to also figure out, do they get an excess of dairy that might lead to iron deficiency? And finally, we ask about, has your child reported leg pain in the last month? Does your child have rashes? Do they have bleeding sores around their teeth or gums? Have you noticed little red or purple spots under your child's skin? So we're asking about manifestations of nutrient deficiencies of different ones. And some of them, like, have you noticed your child losing hair? That's not necessarily for one specific deficiency, but more for malnutrition more generally. So we can kind of get an idea of what their nutrition level is or status is. Okay. Before we move on to the group studies, I do want to talk to you about just a few more things. I do want to let you know that this slide looks at 10 different studies. In all but one of these studies, children with autism spectrum disorders had more limited diets than a comparison group of children without autism. So when I talk to you about kids with autism having more limited diets, I'm not the only one that finds this. Only one of these studies, Schreck et al., is our study. All the rest are different researchers. And all these other researchers have also found that kids with autism have more limited diets. So this is a pretty widely found or pretty broad finding. Before you think about doing an intervention, just like, what are some of the initial considerations should you have? One of the things you should look at is just how bad is the child's diet variety? Do you suspect nutritional deficiencies? Does the child eat any foods from some food groups? And it's pretty typical for us to see kids that eat no fruits, no vegetables. Their meat, if you would want to call it that, is a chicken nugget. And sometimes they very often do have some form of dairy, and they often have things, they often eat nothing but snack food. So that's pretty typical for us. So if that's the case, certainly that does suggest that intervention would be warranted. What is the child's weight status? If the child is underweight, and especially if they're significantly underweight, certainly that's a consideration for treatment. And it may be that one of the focuses of treatment needs to be to increase weight gain prior to increasing diet. They're not the same goal, and you don't have to, kind of the decision of which one to do first is one that you'll have to think about and talk to others about as well, like what are the family's major concerns. How ready is the child for treatment? Does the child sit at the table? Does the child tolerate having new foods on his plate? Does the child snacking all day long? So you want to look at some of those things first. It's not uncommon for us, the initial treatment has nothing to do with increasing diet variety, but rather having the child sit at the table, having the child just allow new food on the table. Because if the child doesn't even sit at the table consistently, it's going to be hard to make changes in their diet. So if you can work on some of those things, you are working on developing instructional control. So that makes things a little bit easier. There are a number of things that families are told. And you need to kind of be aware of some of those things. What advice are they given, or have they been given in the past? Because that's going to kind of, what they've been told in the past is going to necessarily affect what you're doing, because it may be that they've not gotten good advice in the past, or advice that's not just not true, and that may affect how they see you and your intervention. things that very often parents are told that that they relay to me in the clinic is just provide your child with the family meal and healthy snacks such as fruit. All children eat when they're hungry. First, that's not necessarily true. If it were true, I wouldn't see so many children on gastrostomy tube feeds. And second, it requires parents withhold food and sometimes withhold food for prolonged periods of time. And this can be very, very difficult with some children. Third, it may require considerable response effort for the child who has to eat new foods in common with who has very few foods in their diet currently that are in common with the family. So you're asking them to completely change their diet. Which is why we don't typically, that's advice is we call the family meal plan. And we do use it for some kids, but we don't use it for most. It's also been suggested parents modify the food or food preparation, like you can make food more fun, you can cut sandwiches into shapes, you can cut sandwiches into the shape of a Mickey Mouse head, have the children prepare foods, offer foods on colorful plates or incorporate food into a game. Yeah, parents can do that. It's not going to work, but they can do that. So it's pretty typical for parents to get some of these pieces of information that just necessarily are not helpful. Now, one of the things that parents ask me all the time is like what some of the goals should be or what some of the outcomes should be for treatment. There aren't really any hard and fast rules for the number of foods a child should eat, but consider the following as possible guidelines. It would be good if the child ate at least 3 to 5 foods from each of the following food groups: fruits, vegetables, meat or meat substitutes, starches, dairy or dairy substitutes. So if they can eat several foods from each of those food groups, you've got a really good chance that that child is going to be able to get all their nutrition from their food and not need to rely on either supplements in the form of either a supplemental drink like a Pediasure Boost type thing or multivitamins. The child will eat 1 or more foods from the family meal most of the time. I wouldn't expect any child to eat every food from every family meal, but if they can at least eat some of the foods from the family meal, the family can have a shared meal, and you can always supplement the child's meal with some other fruits or vegetables or something else that the child does eat. So if certainly having shared meals is a goal for many families. The child will eat in settings outside of the home. That is huge for some families. It's not atypical for us to see children who only eat in one place, possibly the Golden Arches or maybe one local pizza place. So it limits the social opportunities that the family has. So if you can get the child to eat in settings outside of the home, and especially a range of settings, makes things a lot easier for the family as well. And finally, the child is able to achieve appropriate growth and obtain adequate nutrients without supplementation. So the goal is to have them grow and develop by using food as their energy source and not using supplements. Now, we're going to talk a little bit about group-based interventions, and this is something we've been working on for a number of years, both in regular education schools and now in schools for children with autism spectrum disorders. I think these types of public health interventions are really important, and I think they're can be wildly effective, and I think they're efficient because you can work with large groups of children at a time and not just one as you do in the clinical setting. So this is why we're increasingly trying to do more and more interventions in school settings. Now, a couple of years ago, I had a graduate student, and she was an autism support teacher and I supervised her master's thesis. And what she did for her project was she had a classroom-based intervention for the children that were in her class. She introduced fruits and vegetables in very brief taste sessions in the classroom. She compared the use of rewards and teacher modeling. So she had these two interventions, and she was just trying to find out which one was better. There's research that show rewards work to introduce new foods, and there's research on modeling, and she just wanted to compare the two. For 4 of the children, both interventions worked equally. For 2 children, reward worked better than modeling, and for 1 child, neither intervention worked whatsoever. And I'll show you his graphs. So this is a look at the number of bites eaten by food for reward and teacher modeling. So the dashed line is the modeling, and the solid line is the rewards. And you can see for the first data point is first 2 data points are for squash, and it looks like they're equally effective. They're a little less effective for cauliflower, spinach, blackberry, and apricot, and look like they're just about equally effective for kiwi. These foods were selected because the children in that classroom did not eat them. So this teacher obtained a food preference inventory and found out which foods the children ate and which foods they didn't. And these foods are selected because they're either not eaten ever, or the parents reported they didn't eat them, or I think there was 1 child that ate blackberry once in a while, but not consistently. Now, when you look at the average number of bites per session for each participant by condition, now 10 was she only offered 10 bites of each of these foods, so they couldn't eat more than 10 bites. So participant 1 ate on average 9 bites with the modeling condition, 10 with the reward condition. Participant 2 did just as well with each condition, but ate fewer bites. He only ate on average 4 bites per session. Participant 3 ate 10 bites per session in both conditions. And participants 4 and 5 ate fewer bites in the modeling condition than they did in the reinforcement condition. And participant 6 ate about the same in both conditions. Participant 7 never ate a bite of any food in any condition. What was the utility of this study? I think it was an important study. We haven't published it yet, but I think the things that were important about that study, it was implemented in the classroom by only classroom staff. If you look at a lot of school-based studies, the school staff doesn't implement the study. It's usually researchers. And when does that study end? As soon as the researchers pack up and leave. And typically then nothing's maintained. I think that's the wrong way to go. And I think kind of the future of school-based studies are figuring out how we can get school staff to maintain things over time. This study used very little instructional time. She did a brief taste session in the morning. She did a brief taste session in the afternoon. They were 5 minutes long. That was it. The cost was limited. She had the cost of the fruits and vegetables and a bunch of chintzy little prizes that she gave out in the reinforcement condition. And there were things that she got on one of those online stores that have all kind of little prizes where you can buy them in bulk. It would be easy to replicate this. The procedures are pretty easy, and certainly they could be done in essentially any classroom. It would have probably been easier. It would have probably been easy to increase the number of bites eaten or thin the schedule of reinforcement. That really wasn't the goal of the study. So we had she was using CRF for this. And I think that could have been thinned out more. We only worked on 10 bites. She probably could have gone to a larger portion sizes. in this study, 6 of 7 children were responders. So it did demonstrate that some, not all, old participant number 7 really didn't do anything, but they could benefit for this kind of group intervention. So I thought this was a nice study and one that could be done in the classroom. So if you're in a public school building and you're the only classroom, maybe the only autism support classroom in that building, you can still do interventions to work on increasing diet variety. Now, it doesn't have to be a autism support classroom. It could be any classroom if a teacher was interested. They could probably do stuff for snacks. So this is something that absolutely could be used. We've been working in another school for children with autism, and we've been trying to do some more school-wide studies. And one of the interventions that we've been working with or developing is called pre-meal presentation. We've been presenting children with autism with vegetables in the school setting, and in this study, we compared 2 conditions. We presented the vegetable with lunch, and we presented the vegetable prior to lunch. Presenting the vegetable alone worked for some children. It didn't work for many if you present it with lunch. They eat significantly more when you present it prior to lunch. We adjusted the plan and reduced the amount presented to little tiny specks, and this adjustment increased acceptance. This plan was very low effort and low cost. The only thing you're doing is just presenting the food on a little tiny paper plate. We've got little tiny pieces of vegetable and we're presenting on a paper plate. That's it. There is no reinforcement, there's no modeling, there's no other components. It's just presenting the food before they're given lunch. The goal of developing a plan like this is to see how little effort can be used and still have children that respond to the intervention. And because I want to develop plans that could be repeatedly used by school staff over and over. Because one of the things that we know about the development of taste preferences is that you really do have to have repeated exposure over time. But what we also know about the development of taste preferences is the exposure can be minimal. It looks like what we call in the medical field, the dose is not important. So the size of the piece of food that they taste can be the size of a grain of rice, and that's equal to eat an entire portion of that food. Like you get the same exposure from it. The important part is not dose, it's frequency. It really is important to taste the food over and over and over if you want to develop a preference for that particular food. Now, here we've got a graph that in the top panel is where we just go from baseline where they have the food with their meal. And they really don't eat very much there. And in when we drop in treatment, and for the top panel, you can see it starts to trend upward. So just presenting that vegetable before the meal, they start eating it more. Now at the bottom, we kept them in baseline for a prolonged period of time, and then we moved over to treatment. They did not respond to treatment. So this other group, the bottom panel, didn't respond to treatment, but we also found out that not all of them were sitting in their chairs when foods were presented. So I think we didn't, our groups were not equivalent, but we were happy that at least we got some response from the treatments in this one group. Pre-meal presentation was not enough to get about half of the kids responded. When we looked at the numbers of responders, we had just about 50% responded to the intervention and ate the vegetable fairly consistently. But that wasn't enough. I thought we needed a larger percentage of the sample to respond. So one of the things we wanted to add was add modeling to pre-meal presentation. So we wanted to see if you could get more responders by doing this. The classrooms were randomly assigned to 2 pre-meal presentation conditions, both with and without modeling. For the method for the modeling, and we called it model and prompt that we did, staff members would present the vegetables 5 minutes prior to participants' regularly scheduled mealtime. The modeling staff member had an identical plate with vegetables in front of the participants. So this model, this staff person who is the model, is up in front of this group of participants. He or she makes a positive statement about the food. This looks good. Ate a bite and delivered a soft prompt. You should try it. The model repeated this step 4 to 6 times within the 10 to 20 seconds between bites. So they did a couple of models, or implemented the modeling a couple of times, and then let the children eat or not eat their vegetables. Here you can see, and we did the baseline and then pre-meal presentation and then the model and prompt. So the responding was higher in the model and prompt group, which is to the far right. But it wasn't that much higher. We were hoping it would be a lot higher, but it wasn't that much higher. So I think that's one of the things that we want to work on. Helen Hendy actually did some work on modeling with preschoolers 20 years ago. In 2000, she did a paper on teacher modeling, and what she was doing was, first she asked the teachers, what type of intervention do you think would work best to get children taste new foods? And the teachers, she asked this group of preschool teachers, reported that they thought modeling would work best. And that's the intervention she ended up using. Well, one of the first studies she did, she compared silent teacher modeling, where the teacher would sit at the table with these little preschoolers and eat these novel foods. They had some novel foods on a plate, and the teacher didn't say anything about the foods, didn't prompt the children to eat it. She just sat there and ate. And it didn't really, both the control group and the silent teacher modeling group, actually across the 3 meals, were tasting fewer new foods. So she developed another intervention where she had enthusiastic teacher modeling, where the teacher says, oh my gosh, I love these mangoes. And mangoes was one of the target foods in this experiment. And she found that the treatment group that received enthusiastic teacher modeling did much better in terms of taking bites of new food than the control group over 5 meals. So I think that's something that, I know this literature. I, in fact, have talked to Helen about this and read their studies. I probably should have maybe we could have done something a little bit different. I think that's part of our plan. We're reviewing the literature currently to find out how modeling has been used to increase acceptance of new novel foods. We're looking at both group studies and single subject studies and different case studies. So we're trying to find out how modeling has been used to increase acceptance. And I think that's one of the things that we want to do, is try to how can we change our intervention to make it a little bit better? And I think one of the things we'll do is probably compare some different modeling interventions to see which can be more effective, because there's not very much done on video modeling. So there's a whole bunch in terms of food acceptance. There's a ton done on video modeling, but not really in the food arena. So we want to try to look at some of those things. I'm going to tell you a little bit about the Kids' Choice Program, which is it's a large-scale intervention we did. We've been doing it we've done it for years. We've published 4 different iterations of this study. And this study, the goal of this is we were working in elementary schools. Our goal was to develop interventions that could be used on a larger scale. And this particular, the Kids' Choice Program was really designed to be used in an elementary school setting. But I think that many of the things that we did can be adapted to other settings, and that's one of our goals, is to do that. The Kids' Choice Program had 3 goals. We looked at 3 weight management behaviors. The first was to eat fruits and vegetables first during meals. There's a number of articles in the literature that show that if you eat certain foods first, namely typically salads, vegetables, vegetable soup, if you eat that food first in your meal, the whole serving of that food, you can decrease caloric intake by about 12%. Barbara Rolls and her team at Penn State have done a number of studies in which fruits and vegetables first have been shown to be effective in decreasing the caloric intake at meals. Another goal is to have children select healthy drinks. At the time, they had chocolate milk as one of the drinks and skim milk as a beverage. I think they had whole milk as well, or maybe strawberry milk, but the goal was to have children choose skim milk. So we could, because if you look at, and in fact, in the data from a couple of our studies, we looked at what are the different things that kids could do that would promote the largest decrease in caloric intake, and it's changing the drink. Going from chocolate milk to skim milk across the span of a year, if you do nothing but change the type of milk that the child drinks, it's a decrease in thousands and thousands of calories by doing nothing but that. And finally, we did exercise and just taking many steps daily. We had a couple of, one of the iterations of this intervention of the Kids' Choice Program, we did use pedometers. I would not recommend doing that ever again. That just did not work out well for us. Little kids are rough on pedometers and lose them, step on them, drop them in the toilet. It was not helpful. So we just kind of reported whether they went out and did anything at recess. We wanted to increase preferences for these behaviors, and we wanted to look at improved weight status. So those were kind of the goals of the program. Here you've got 2 pictures, and then on the left you've got the one of the research assistants, who's actually now a professor, passing out baby carrots and bananas. And on this young lady's plate on the right, you can see the banana and the baby carrots. And you can see there's not their portions of the target foods are very small. And around this young lady's neck, you see a Penn State paw. And that was what we used for our token economy. So when the children exhibited the target behaviors, they would get a hole punch in their Penn State paw. And then those, the hole punches could be turned in for prizes at when we had an exchange day. So it was once every 2 weeks, I think we had an exchange day. So here you see the child eating, this little girl eating cherry tomatoes and a young man pointing at her. And they're also, you can see the banana that she's got on her plate. So the amount that they were required to eat was very small. We were just trying to get them to eat small amounts. It was about 1/8 of a cup, which is just a few cherry tomatoes and a little piece of a banana. Here you can see incidental peer modeling. So you've got a number of kids that are all eating the same food. So they would be able to, so they were not only saw each other eat the food, but also saw each other get reinforced when they engaged in the target behavior. So we did use peer modeling. We didn't measure how the modeling worked. So we're not sure, it was just incidental modeling, but nonetheless, there was a modeling component. In one of our studies, this is the third iteration, we had 382 students from first to fourth grade in a small town in Pennsylvania, 211 boys, 171 girls. Of this sample, 120 children were at risk for overweight. So 35% of the sample was at the 85th percentile for their BMI or higher for their BMI. We had two groups in this, of participants. We had an intervention group we called the Lions, and we had a control group we called the Tigers. So the Lions are the ones that got reinforced for what we called good health behaviors, which was selecting the low-fat milk, eating fruits and vegetables first, and engaging in some form of exercise. The Tigers were reinforced for good citizenship behaviors, which were doing something nice for a friend, cleaning up after themselves, and not yelling in the cafeteria. So we just picked these three kind of pro-social behaviors to reinforce. The study phases the baseline lasted a month. The reinforcement stages or phase lasted 3 months, and follow-up lasted 2 weeks. We had follow-up at 2 weeks, and we had follow-up at 6 months. We had 2 follow-up phases. Now, the top panel of this is the fruit and vegetable first. So here you can see the top line with the squares and the solid line is the intervention group. The bottom line is the control with the solid line and the ovals. And that's for all of the interventions for all 3 of the panels. You can see the intervention group did better than the control. So intervention did work to increase fruits and vegetables first at the meal, increase healthy drink choice, and increase exercise. And we've got these at the different times are 2 weeks, 4 weeks, 10 weeks, and 12 weeks. So that's what the different panels are. So this is for the group, this is what the changes were. So the intervention did work to change all 3 target behaviors. And this is what I think is by far most significant. This is weight status for just those 120 children at risk of overweight. So a year before, their BMI was almost exactly the same at 94%. It was just a little bit less than that at baseline, about 93%. And then after the program, so this is 6 months after, their BMI had decreased for the control group as well, but not significantly. It was like at 93 or something, but it had gone down to almost about 91 with the intervention group. So this program, even though it was not carried out at the home whatsoever, and it was only done in the school at lunch, resulted in a decrease in BMI. This is virtually unheard of. Almost no other school-based program even looks at weight, and most do not find changes in weight, the ones that do. So this was a big deal. We were very happy to see this. And the part that we were pretty amazed at is more typically, we're actually surprised that the control group went down, because usually BMI typically trends upward. So we got it not only to go down in both groups a little bit, but one significantly down. We would have been okay with, if it would have been not gone up, we would have still considered that success. Okay. Okay. Now I want to talk to you about something we're doing right now called the Lunchbox Study. This is the first study that has examined the contents of packed lunches of children with autism spectrum disorder. We had 62 participants from 5 schools who teach children with ASD. We had 1 school from Connecticut, or 1 each from Connecticut, PA, and New Jersey, and 2 schools from New York. And our participants were 51 males and 13 females, with a mean age of 162 months and a range from 65 to 249 months. Previous research on packed lunches has generally shown 2 things. 1, that packed lunches contain fewer healthy foods than school-provided lunches, and packed lunches often are high in energy-dense foods, like snack foods and crackers and that sort of thing, and low in nutrient-dense foods like fruits and vegetables. So we wanted to find out, is this true about children with autism? How do they stack up when you compare them with children without autism? So it's never been looked at, so we thought this would be something that would be interesting. We compared, there was a study that was done by Katie Hubbard and her colleagues at Tufts, and we used some of their methodology, especially on how to categorize the food. And we compared the 64 kids that we worked with. We gathered data for 5 meals for each of those children. So we looked at 320 meals, and Hubbard and her colleagues looked at 626 meals. They're different children. So we used different methodology, but I just wanted to roughly compare how these 2 groups did, because we did use the same food categories. We looked at the National School Lunch Standards was established by the Department of Agriculture. And one of the standards says the child should have 1/2 cup of fruit in their lunch. Well, the children that we saw actually consumed 1/2 cup of fruit 38% of the time. Hubbard's participants had 32% of the participants, they had fruit in the lunch. They didn't necessarily consume it. One of the school lunch standards is you've got 1/3 of a cup of vegetable in your lunch. In our sample, 14% of the children consumed 1/3 of a cup of vegetable. And Hubbard's sample, there were 6% that had a 1/3 of a cup of it, not 1/3, 3/4 of a cup of vegetable in their lunch. One of the standards is that there's 1 ounce of a grain in your lunch. And in our study, we had 67% of lunches met that standard, and 65% in the Hubbard study. 1 ounce of protein in the lunch was one of the standards. 77% of the children in our sample met that, and 66% of the Hubbard sample. So the one that we didn't, that our sample was lower than Hubbard's sample, was the 8 ounces of milk. So children have 8 ounces of milk. Nobody in this sample consumed 8 ounces of milk. And in Hubbard's sample, 15% had 8 ounces of milk in their lunch. So both of them I thought pretty low on the milk. But I was actually pleasingly surprised that our sample stacked up to this large sample of children without special needs in regular ed elementary schools. Now, why do I think our sample ate better? Why did they do better than this other sample? In all 5 schools, the school staff would heat foods and prepare foods as needed. And this allowed children with autism to bring leftovers, pizza, macaroni and cheese, ethnic foods, all of which require warming. That was a huge difference, and I think that was the important part, that they could the foods that parents sent in these lunches, they were all kind of microwave meals, and so it wasn't just a peanut butter sandwich and a bag of chips and a piece of fruit that, you often see in packed lunches. It was a pretty wide variety of stuff. And I think it's unknown if in other school settings, if parents would pack differently, knowing that food could be warmed. But I do think that was one key component that kind of made our sample do a little bit better on the national school lunch standards. One of the things that I think the most important thing that we've uncovered in this study, we looked at, we just did a frequency count of how many foods did the children pack in their lunches. And then we looked at how many of those foods that they packed did they actually eat. So we looked at whether the food was more than half consumed or less than half consumed. It's kind of hard to do some of these measures. So we just made this kind of a gross measurement of half consumed or half not consumed. And we found that if they brought 4 foods in their lunch, not counting the beverage, that 46 of those meals, they had more than half of each of the foods consumed. If you looked at the foods in which they packed 5 or more foods, only in 22 meals were more than half of the foods consumed. If you looked at the foods, if you looked at number of meals with less than half of the foods consumed, you saw that only in 22 meals when there was 4 foods, and you saw it in 44 meals when there were 5 or more foods. So when the more foods you pack, it doesn't guarantee that they eat all of those foods. It looks like it guarantees that you're going to have food left over. Now, that's the other thing we wanted to look at was what are the things that are left over? When you have that many choices, what do the children choose? And more importantly, what do they not choose? Well, we found out that fruits remained in 31 lunches, vegetables remained in 12 lunches, desserts remained in 10 lunches, leftovers remained in 8 lunches, snack foods in 8 lunches, dairy in 7 lunches, and sandwiches in 3 lunches. So the foods that we really want kids to eat, fruits and vegetables, are those that are most likely to be left in their lunch when they're offered 5 or more foods. So I think this can be a public health intervention that's probably the easiest one that I've ever thought of. If you ask parents to start with a fruit and or vegetable, put those in the meal first, and then just add 3 more foods, do nothing else. It doesn't matter what the other 3 foods are, just put those in, but not more than that. I think you're going to have a better chance of them consuming the fruit and vegetable or vegetable. And I think that's one of the things we'd like to look at. So I'm hoping that that'll be one of the kind of doing something like that is going to be a future study, because that's, they've really not looked at that. If you look at the literature on packed lunches, they've really, I don't think anybody else has done just a simple frequency count of how many foods are packed in the lunch and what were they. We know what's, if they bring fruits or whatever, but they don't look at just a simple frequency count. This is, I think, the first time I've ever seen it done. So that's going to be one more thing we'll do in the future. Now, why do I think 4 foods were better than 5? We suspect that children ate more of the fruits and vegetables when there were 4 foods. Because when there were 5 or more foods, the children could more readily choose between healthy foods and discretionary foods. Discretionary foods is just now the fancy name for junk food, like chips, pretzels, other types of snacks, and the healthy foods just remained in lunch bags. This really points to the power and the importance of motivating operations. If you don't consider hunger in the development of your interventions, whether it's an individual intervention or a group intervention, they're not going to be as effective. And just a moment about that. I want to, over the last couple of months, I've heard 2 different things that I think were I think not true. It's not that they're not true. I think they're unfortunately the persons that made these comments didn't understand motivating operations. I can only work on feeding. I can't make diet suggestions, was what one parent was told by an unknown EI provider. And another parent was told the only thing that matters is addressing the behaviors. And that was by an unknown behavioral provider. I think both of those things are tragically wrong. If you're an early intervention provider and you only try to work on the feeding and not consider diet, like when meals are offered, when snacks are offered, is the child drinking a bottle all day long, you are not going to have very much success if you're trying to change that kid's diet. You really got to look at this as a total package. And I think that's true for this. The behavioral provider says, well, I only want to look at the behaviors. You really can't only look at the behaviors because the behaviors exist in an environment. You have to look at the entire environment. You have to consider hunger, and you also have to consider comorbid medical conditions like constipation, reflux, food allergies, etc. And when we do our, any appointment that we ever do, the first thing we ask about is your child having problems with constipation? Do they have reflux? Do they any new medical issues? So we always ask about those things because we know that they're going to affect intake. Now, here's something I think that's helpful to know about intake. If you look at your own intake for a 24-hour period and compare it to another 24-hour period, or better, a 48-hour period to another 48-hour period, your intake is probably relatively stable. Now, I mean, it may be that you go to a buffet one day and your intake's going to be dramatically different than the day before, perhaps the day after, but that's not as typical for most people, I'd imagine. But typically your intake from longer periods stays stable. However, within a day, your intake from like meal to meal is wildly inconsistent. So if you eat a large breakfast, you don't typically eat a large lunch and then a large dinner. You eat maybe a smaller lunch and a smaller dinner, or maybe you don't eat much at lunch, but then you eat more at dinner. So there's not consistency from meal to meal. And parents often like, well, they didn't eat that much at lunch, so I gave them a Pediasure, or they didn't eat much they never eat much at breakfast, so I give them a bottle of milk afterwards. Well, that just guarantees that you're going to not eat that much at the next meal. That's not how hunger satiety works. So that's something to consider, because I think that's, parents don't get that. I just saw a child yesterday who is on a gastrostomy tube, and if she doesn't eat a certain amount during the meal, then they give her a tube feed, they bolus feed her. And then the parents are wondering why the child's intake is never getting any better. Well, the child's is not developing a hunger satiety cycle. You just can't do it that way. So we're working on changing some of those things, and hopefully it'll make that better. Cecil was a 10-year-old boy with autism that I recently saw. In fact, I've never met Cecil in person. I've only seen him on Zoom so far, because my first appointment with him was during this COVID crisis, and we've only seen each other through on online appointments. Hopefully I'll see him this month or next month. But he's a 10-year-old boy with autism. He eats blended SpaghettiOs and meatballs and Oreo cookies. He drinks 3 or 4 Boosts daily, as well as water, milk, and juice. The PCP initially suggested that Boost should be used to increase weight gain and ensure appropriate nutrient intake. Well, he started with 1 or 2 Boosts a day, and then eventually he started drinking more, and now he's at 3 or 4 a day. During the initial intake, he placed an entire regular-sized Oreo in his mouth and chewed it up and swallowed it. So I was not worried about him not having good Oreos after. Kind of worried about him choking for a second, but he chewed it up and swallowed it. So I'm not worried about that he can't chew, but this child only chews Oreos. He doesn't chew any other food. He doesn't eat at the table. He walks around drinking booze from a sippy cup. He sits on the sofa and allows his mom to spoon feed him the blended SpaghettiOs, but he doesn't self-feed anything other than the Oreos. What was our plan? Our initial plan was we gave 3 meals a day of blended food and milk. We gave 1 boost in the evening. He could have unlimited water away from the table. And we started placing new foods on the plate with the blended SpaghettiOs. During the day, he was presented with tiny specks of new food and given an Oreo for tasting a new food. So he ate 1 little tiny speck and he got a great big huge Oreo. His mom started with applesauce, yogurt, and other low texture foods. It didn't require a lot of effort to swallow because they didn't even require chewing. At the second appointment, he was starting to taste new foods to get Oreos and has been showing an interest in new foods, sometimes licking or tasting them. So I thought that was nice improvement thus far. Now, why did I use that plan? I reduced the boost to increase his appetite. I used repeated exposure to novel foods to start working on increasing taste preferences, and meals were offered on a schedule so he could start developing a hunger satiety cycle. It's pretty common for us to receive referrals of school-age children who are eating primarily low-texture foods and drinking from a baby bottle. It's important to reduce calories from formula and decrease grazing in order to increase their motivation to eat. So that in looking at motivating operations is very important for if you're going to do work in changing diets. Okay, what are the things that we're going to work on next? Well, in our school-based studies, we're going to try to work on sequentially adding pre-meal presentation, modeling, and then token economy. So one of the things we're looking at with each one is how does the number of responders change? So it may be that if most of the children respond with just pre-meal presentation or modeling, we wouldn't need to add the token economy. In a public health intervention, you don't necessarily look to have 100% of the persons responding. In fact, in most group interventions, you never know how many people are responding because that's not one of the things they look at. They look at a group, an aggregated group scores, not individual scores. We're looking at both score for the entire group and looking at all the individual scores. So I think that's one of the strengths of the research we're doing in schools is we are looking at individual scores. We are planning at other follow-on studies for this at different locations. We want to look at different types of modeling. We want to look at generalization to home. We want to look at schedule thinning for token economy. So we're looking at doing simple interventions for packed lunches, as I mentioned. And this would be one thing, if somebody has an interest in doing school or community-based interventions, you don't have to want to do research. If that's just something you want to do, I'd be glad to help with that. And if you do want to do research, I'd be glad to help with that. And you know, I can, or if you want to do your own stuff, I'd be glad to help you set things up. So please contact me with that. If you want some data sheets, it's located at, let me move. BroccoliBootcamp.com has a bunch of different data sheets that you're welcome to use. If you have questions about anything that I talked about in this talk, you can contact me at feedingprogram@hmc.psu.edu. I appreciate you listening to this, and I hope to hear from some of you about different things you're doing. The assessment is going to be a part of the handout, so we'll have that in there that you can talk. It has the questions for screening for nutrient deficiencies and the food preference inventory and other things. So all be in the handout, so that'll be there. Thanks a lot. I'll see you later. Bye now.